Afternoon. Thanks everybody for coming. Welcome to Memorial Hospital to the seminar. I hope that this information is helpful to you. I'm going to talk primarily about knee arthritis, and I'm going to talk about not only just arthritis of the knee for older individuals, but also for younger individuals, because that's a new option and new techniques that are available that are really, really beneficial nowadays. And if we have time, then I also have some slides on a little bit of shoulder and a little bit of hip as well, because that's always wrapped into the diagnosis of arthritis. Most people have not just one joint involved, but other joints involved. And there's all kinds of paraphernalia here and information and brochures you're more than welcome to grab at the end of the seminar as well. And we'll open it up for questions at the end of the day, too. So we have a very small group here. We have lots of time to be able to answer any questions you might have and go over some specific questions you might have. So I'll start off. Again, my name is Dr. Cohen. I'm with Orthopaedic Specialists here at Memorial Hospital. Been in practice for 30 years and have a lot of experience when it comes to arthritic problems, especially in knees and hips and shoulders. So we're really here to talk about how we try to get rid of some people's symptoms and restore the so-called joy of motion, to get people back doing what they'd like to do. And it's our job as orthopedic surgeons to try to get people back to the way they need to be able to enjoy themselves. And unfortunately, arthritis often interferes with people's daily activities, interferes with people's nighttime activities. Even trying to sleep sometimes can be a major problem. So we have different options available all the way through, from very conservative options all the way through to multiple surgical options to try to correct these issues. So the leading cause of knee pain around, well, it's, as you guessed, it's osteoarthritis. And what osteoarthritis means is basically just the wearing down of a joint. There are lots of different types of arthritis. You've heard of people having rheumatoid arthritis, which is an inflammatory type of arthritis. Osteoarthritis, which is the most common, is simply the wear and tear on joints. And as we get older, unfortunately, these surfaces wear down and cause this so-called osteoarthritis. When we talk about osteoarthritis of a knee, again, the cartilage deteriorates. That's the surface coating that covers over the bone. And in a knee, there are basically three compartments to the knee. And on the picture on the right, you can see the femur above. That's the end of the thigh bone. The tibia down below, which is the shin bone, and the kneecap in front. And so basically, there are three divisions. There's the inside part of the knee, the outside part of the knee, and underneath the kneecap. That makes up the three main compartments of the knee. Down below on the right, you can see the term meniscus right down here, and what that refers to is the cartilage or the cushion or the shock absorber that fits between the two bones. And frequently in lay terms, you'll hear people say, I have a torn cartilage in my knee. What they're referring to is a torn meniscus, which is that little cushion that fits between the two bones here and here, and it lays on the inside of the knee, and there's one on the outside of the knee as well. So the different options for knee arthritis are very early. Medications, weight control is a major situation that needs to be managed. Non-surgical treatment, we'll get into that a bit more detail a little later about different types of medications and physical therapy, and sometimes injections. And there's different types of injections. You've heard of people having cortisone shots. You can have that in a knee, which can be very, very beneficial. And there are lubricating injections, which also can help to try to ease the pain of arthritis. And then at the far extreme is the routine knee joint replacement. And again, lots of those are being done on a daily basis throughout the U.S. So the question is, are you ready for a knee replacement? And this is very, very important. Does your knee hurt one or more days a week? Does it interfere with your sleep? And there's nothing worse than not being able to get a good night's sleep. Is it painful for you to walk more than a block? Are pain medications no longer working? Is knee pain limiting your participation in activities? Has inactivity from knee pain caused you to gain weight? Can you limit activities for a few months to recover from surgery? And are you willing to commit to hard work during rehabilitation? Because when you do knee joint replacement surgery, half the battle is the operation and half the battle is all the recovery and the hard work and the therapy afterwards. Most people, it's not a guarantee, but most people do very, very well with knee joint replacement surgery. So 85% are satisfied, but that still leaves 15% that still may have some issues. And that's really, really important. So if you can prevent somebody from having to have a complete knee replacement and buy more time for their knee, then you've done that patient a service. Again, you should also know that performance of joint replacements depends on age, weight, activity level, and other factors. So again, it's not a guarantee you'll get 100% recovery. Again, most people do very, very well. And there's potential risks with the surgery. There's potential risks after the surgery. You have to be very careful that you don't have an infection or something that would prevent you from being able to rehab that knee. And there are lots of different complications which can result in problems even long-term after the knee replacement is done. You can have loosening, you can have fractures, and you can have wearing of the components. So if you have somebody who's 70, 75, or 65 years of age and you do a knee replacement on them, it's more likely than not that that knee replacement will last them their lifetime. But if you do a complete knee replacement on somebody who's in their 30s or 40s or 50s, that knee is not likely to last them the entire lifetime, and they'll look at some form of revision surgery at a later date to try and change the components out or put new surfaces inside. And the second surgery is always much more difficult than the first, and the results from the second surgery may not be as good as the first. So again, it behooves us as orthopedic surgeons, if you don't need to have a complete knee replacement, to find a different option for you. So again, non-operative options. Before you consider surgery, there's oral medications like anti-inflammatory medications. Sometimes something as simple as Aleve or Advil over the counter can be very helpful. Sometimes just some Tylenol arthritis is all that's required. Injections of steroids or lubricating injections can be helpful. Physical therapy. Some people like to wear a brace on their knee. It gives them more support and comfort. And sometimes people have to use some form of walking aid, a cane, a crutch, or even a walker. When it comes to surgical options, again, we just sort of touched on joint replacement, and we'll go through that in a little bit more detail in a minute. But there's other types of surgery that you can have done too. And oftentimes people that have arthritis in their knee may have something as simple as a torn meniscus or cartilage in their knee. And if you can remove the torn cartilage, that can get some relief into that knee, and they don't need to go off to have the joint replacement done. Osteotomy is an operation that's sort of not done as often nowadays, but in essence, if somebody comes in, they're very, very bow-legged, and they have a lot of pain on one side of their knee, typically the inside of the knee, you can actually do this osteotomy, and it sounds somewhat grotesque, but you actually, in surgery, break the bone just below the knee joint and change the angle. So instead of being bow-legged, you can make them either straight or even a little bit knock-kneed, and it takes the pressure off one side of the knee joint. Again, it's very important that the arthritis is just localized to one side of the joint. And again, it's not done very frequently, but in occasional cases, it's necessary. When it comes to knee replacement, there's all different kinds of knees on the market. There are probably 400 total knees on the market nowadays, made by various companies, and the majority of the major companies, all the knee replacement components are excellent. And the typical one that's put in is called a traditional fixed bearing. What that means is, and I'll show you some pictures in a second, is that the liner that goes inside the joint between the thigh bone above and the shin bone down below is fixed to the top of the shin bone. The one that I use is called a rotating platform, and I'll show you a picture, and we have an example of it over here as well. And that really tries to duplicate what a normal knee does. Most people think a knee is a hinge, and one bone just slides back and forth against the other. But actually, there's rotation of the shin bone on the femur bone, and when you put a rotating platform in, it really tries to duplicate what a normal knee does. A unique compartment replacement is to replace only one side of the joint. And again, I'll show you an example of that in a few minutes as well. And the other thing that we're here to talk about is this new operation called resurfacing. And in essence, if you just have localized arthritis in a small area, instead of having to do a complete knee replacement or even a partial knee replacement, you can cover up part of that arthritis with this resurfacing, typically done as a day surgery or an overnight stay. You basically keep your own knee. Again, this rotating platform tries to duplicate what a normal knee does. And the results for that typically show a 90% patient satisfaction after a 5-year study, which is excellent for knee replacement surgery. And that's what it looks like. It looks relatively large, but when you look at the actual component over here, it's not as big as what you think. But this is the end of the thigh bone that's covered with a metal shield. So basically you remove the arthritic surface. You remove the arthritic surface off the top of the shin bone. And this is the rotating platform. This is a piece of plastic that slides back and forth on this, but also spins on this plate. So it allows for actually a very normal feeling of that knee. So what do you do with or without knee replacement? Well, if you have severe pain, you can't get around, medications don't help, you can't sleep, then you have the option of having surgery if you qualify for it. If you have the surgery, typically it takes a couple of months to rehab that knee. Lots of work to be done during that time, and that's really half the battle. And then typically at 3 to 6 months, people feel relatively comfortable. Sometimes it takes even a little bit longer for you to actually feel like that's your own knee. If you don't have the surgery, of course, then you continue to have the same pain you had before, and you might try, again, some more conservative measures to try and cut back on that knee pain that interferes with your activities of daily living or your sleep. Women, it's very, very important. Osteoarthritis affects 3 times more women than men, and women's knees rotate more than men's, and so they really benefit from having this rotating platform put in. There's been a lot of publicity about having to have a knee joint that's made for women. That unfortunately was, it all came out from one of the major companies that their components were actually larger than they should be, and so in order to make it look like they have a knee specially designed for women, they came out with a separate line that was designed so-called for women, so smaller components. But all the major companies make components that basically fit for women and men. When I do the operation, we do it with a computer that actually hooks up to the leg, and the computer actually reads all the data off the knee, and we have a component that fits for that individual. So whether you're a woman weighing 140 pounds or a man weighing 300 pounds, we have components that fit everybody. And when we're in the operating room, we have all different options available to be able to cover those knees. Again, I touched on the fact that we use a computer. We literally plug a computer into the leg, and it's really, really unique and very high-tech, and it really helps us to be able to take the right measurements during the operation to remove just the right amount of bone off the arthritic surfaces as shown here. And then the most important is to line the leg up. So if somebody comes in and they have, again, a bow leg or a knock knee, or if they can't straighten their knee out all the way, the computer gives us enough data to be able to almost within a degree or two make that knee perfectly straight. If you don't put it in properly, and if you do have some more angles in the knee than you would want, then it potentially can lead to early loosening, to wearing of the plastic liner that fits between the 2 metal components, and poor function. And this is really, really important with somebody who's really young. So if you do this in somebody who's 80 years of age, you're not as worried about it wearing out. But if you put a complete knee replacement, as we do sometimes, unfortunately, in people in their 30s and 40s, you need to have that knee put in as perfect as possible so that hopefully that knee will last a lot longer. So in navigation, it's basically having a GPS system. You see people driving around, they have GPSs in their car. Planes fly with GPS. This is actually having a GPS system attached to the knee while we're doing the operation. And that's what the operating room looks like. Actually, there's a little monitor, and we're actually looking at the monitor. That's the knee, and we're looking at the monitor as we're doing the operation. It actually gives us all that detailed information. Has all different kinds of names. You'll see in articles in the newspaper, computer-assisted, image-guided, computer navigation. They all basically mean the same thing. And there's all different kinds of computer systems available. The one that here at Memorial Hospital is a very expensive system. It costs almost $300,000, and it's well worth its weight in gold. We've been using it for probably about 5 years now, and it actually makes the operation, I think, a lot cleaner, much more accurate. That's what it looks like. That's the monitor over here. That's actually the system that actually plugs into the leg while we're doing the operation. And that's the computer camera that actually takes information, screens it down to this, and then it goes over to the computer, and that's how we get all the information during the operation to be able to make sure we're doing this very, very accurately. Again, why are we using it? There are not a lot of surgeons that are using it, but those that are very, very happy with it, and I think our results show for itself. It does a very, very good job to make things much, much better for the patient long term. We can also make smaller incisions because the computer sees more than we need to if we had to do it with the open eye. It makes intraoperative decisions very, very technical and very accurate, more precision and accuracy, as I mentioned. And most people actually want the latest technology, and if that was my knee, that's what I would want too. So somebody who is actually very heavy set, for example, it makes it a lot easier to do the operation because we can see more through the computer than we can even through the naked eye. All kinds of information during the operation for the surgeon to be able to make specific measurements and decisions as to where we're going to put the components. Very precise and accurate data, and it fine-tunes the knee, again, down to a millimeter and a degree of accuracy, whereas typically they've done studies that if you don't use the computer, you can be out as much as 8, 10, 15 degrees on your accuracy of putting the components in. Again, I mentioned a partial knee replacement. That's where you just replace one side of the joint. Typically, it's the inside part of the knee that's replaced, but it can be done on the outside. And this resurfacing surgery I touched on as well, and we'll get into a bit more detail on that again in a minute. So again, this resurfacing is done arthroscopically. Part of it is done arthroscopically, and that's just unbelievable that nowadays we can replace part of the knee joint through a small telescope. The nice thing about it is you still have your own knee. Instead of a total knee or even a partial knee where we actually change the mechanics of the knee joint, you basically still have your own knee. All we're doing basically is to cover up a localized area of arthritis, and I'll show you a picture of that in a minute. So you maintain your normal function, you maintain your normal range of motion, you can be very, very active with this in place, lower complication rate. What we're trying to do is buy time, and for somebody in their 40s who has localized arthritis, up until recently, up until several years ago, they really didn't have any choice other than to bear with the pain, try other operations that wouldn't be successful for them, or go to a much bigger operation that I think was basically overkill for them. So with this procedure now, you can actually buy time, and if you can get another 8, 10, 15 years out of that knee before you commit somebody to having a complete knee replacement at age 40, then again, you've done that patient a service. And the nice thing is that you just basically address the pain generator. So what that means is if you have localized arthritis in one area of the joint, you cover up that area, then that pain disappears from that knee. So here's a typical patient, a 40-year-old person. They again have localized arthritis in one area of their knee. And whether it's based on some form of trauma, they hit the dashboard in a car accident or fell playing sports, they have a localized area called AVN where there's a circulation problem to that bone. A part of the bone has become loose inside the knee, or they just have developed localized arthritis, then you can go ahead and resurface it. The key thing is it's important to have it just in one area of the knee, so you don't want to have major problems elsewhere. If you look at somebody's knee joint, or if you look at any joint in the body for that matter, the covering over the bone is this white, slippery, hard, shiny surface. If you look at a fresh chicken leg, for example, and you look at the ball of the chicken leg, it's covered with a white, pearly, shiny white surface. If you take a razor and cut through it, there's bone underneath that. And so when you have arthritis, whether it's localized or diffuse through the knee, it's the wearing out of that white, shiny surface on that knee joint. That surface has to be very smooth, it offers stability to the knee, and everything glides inside the joint as it should. And it covers all the bone ends inside. So if you look inside a knee, and this is a picture through an arthroscope, this is looking at somebody's knee, and you can see the white surface on the outside is fine. But this area right here, which is localized, is worn right down to the bone. Now, if they have this only on one area of the knee, it's crazy to go ahead and change out the entire knee joint. It's actually crazy just to change out the whole one side of the knee. If all you have is that localized area and you can cover that up with an implant, then again, it's done as a day surgery typically or overnight stay, and it gets rid of that so-called pain generator, and it's a much easier operation to get through, and that's what it looks like. This is the component that would cover over the end of the thigh bone. It's a small component. The rest of the knee is still intact. It has a fancy little titanium screw that goes up into the bone, and this cap covers over the end of the thigh bone. If you have a little localized area of arthritis on the shin bone, you can also cover it with this little implant as well. Again, that's the part that's done arthroscopically. Before all this was available, there was options of, and this is an unusual picture, but that's basically a cartilage transplant. That somebody has a localized area of arthritis, similar to what you saw in that previous picture, and we can take the cartilage, send it off, have it grown in a test tube, they send it back to us, we go ahead and implant it under a flap of tissue, and you hope that that surface will grow, and it'll cover up that surface, and it'll be much like this over here. Unfortunately, that doesn't work very well. If you were 25, 30 years of age, it's worth a trial to go ahead and do it. But unfortunately, this typically does not stand up to the rigors of activities, of sports, and just long-term walking. This is what a partial knee replacement looks like. Again, the outside part of the knee is okay, the kneecap is okay, but the inside part of the knee has been completely replaced, unlike what we're going to talk about, and I'll show you a picture in a second, of the resurfacing. And if they have arthritis diffuse through the whole knee joint, then you have the option of going ahead and replacing the entire knee joint, as we just talked before. That's the covering over the end of the thigh bone. There's a cover on the top of the shin bone right here, and there's a cover that goes behind the kneecap that doesn't really show very well because the lights are a bit bright. But again, if you have localized arthritis, you can go ahead and cover it with this little implant right here and that little plastic implant right here. And again, a picture of an area of localized arthritis on the end of the thigh bone. Significant pain from that. But the rest of the knee is okay, so you cover it with this implant right here, and it gets rid of that problem. If they have localized arthritis in the shin bone, again, you can take this little plastic dial and you can put that inside here. That's done arthroscopically, and people do very well from that as well. And that's what the x-ray looks like right there. And that's the side view right here. So the cover goes over the end of the thigh bone, the titanium screw goes up into the bone, little plastic dial right here, and some cement, that's bone cement that's injected up through the shin bone to go ahead and protect that. Again, those are the dimensions. That's not really important for the topic today, but that's what it looks like. And that's what it looks like when you're inside the knee joint. The interesting thing is that's the metal shell, and you're actually seeing the reflection of the plastic on the metal that's covering over the end of the thigh bone, and that's the little plastic dial that covers over the localized arthritis inside the knee. And that's the inside meniscus or inside cartilage that's still intact. Here's a typical example. This is a 41-year-old male. Now, if he went to most surgeons around town or even anywhere else in the States, they would look at that and they would probably do a partial knee replacement or a complete knee replacement on him. But he's 41 years of age, and the likelihood of something like that lasting him 20, 30 years is very, very small. He's very active, he works offshore, and he really wants to have something that he can get rid of as much of pain as possible and still maintain an active lifestyle. So on the right knee, we were able to go ahead and accomplish this. We went ahead and resurfaced the inside part of the knee and put this little metal dial up underneath the kneecap to cover that as well. He still has the rest of his knee. The rest of his knee is intact. That's looking at from the side view there. There's his kneecap right there. And again, he's very, very active on that right knee. He does not have a complete knee replacement. It is hoped that this will last him 8, 10, 15 years. We don't know how long it'll last, but if it lasts that long, he's gone that much further down the road before he has to commit to a major knee replacement surgery. And on his opposite knee, his arthritis was worse, and that's the nice thing about these new components. You can mix and match. So on the inside of his left knee, he has a partial knee replacement, and again, he has a little larger shell that covers up underneath the kneecap. And again, that's looking at it from the side view here. And again, most people would have gone ahead and done a complete knee replacement on him, but with this, again, he's pretty comfortable now. Again, he's gone offshore, he can work, and we hope that that's going to last him a long time. That's what it looks like underneath the kneecap. That's the metal shell that covers right there. The kneecap is right above here, and that's what it looks like on the front view right there. Again, you still have your own knee. We've just resurfaced one small part of it. All different shapes and sizes for the plastics that you can go ahead and put inside. And that's what it looks like inside the knee through a small incision. Here's a patient that's just 6 days post-op. That's the size of the incision typically. It's relatively small. And they're able to bend their knee very, very quickly soon after the operation. They still have their own knee, so they don't develop all the same stiffness problems they would have if they had a partial or a complete knee replacement. Take a break just really quickly and move. Anybody have any questions so far about knees? And we'll get into some more question period in a second. But anything that sort of comes to people's mind right now yet before we go off to shoulders? Okay, this is really brief on shoulders for the same reason. Okay?
You are pointing.
Yes.
We can't see your pointer on there, so
Okay.
say the right.
Okay, that's great. Okay, thanks. Just a couple of brief things about shoulders is that they're the same company that makes the resurfacing for the knee makes components for hips and for shoulders as well. And so again, in shoulder arthritis, when it gets to be very, very bad, you have the option of a traditional joint replacement, which I'll show you a picture of, or you can go ahead and resurface that as well. So somebody who has complete arthritis in their shoulder, and that's a picture looking at there on the side right here where the bone is rubbing right against the socket. That's the ball. That's the socket. There's no space whatsoever between the two. Then they have the option of having a joint replacement done. You can either go ahead and replace just the ball part, or you can replace the ball and the socket depending on what's necessary. And that's what it looks like in a traditional format. You go ahead and remove the entire ball, and you put this large component that has a stem that goes down inside the canal. Unfortunately, it has potential complications, as any surgery would have, but much bigger complications than if we resurface. So all different kinds of problems, a much bigger incision as well to go ahead and do this operation. But if you have localized arthritis inside here, again, looking at this top left picture, there's the ball right here, there's a socket, it's worn against the two, there's a big bone spur down here. You can go ahead, instead of putting that large component in, you can go ahead and resurface just one side of that component, of that joint. And so the bottom left picture just shows that cap that goes over top of the ball attached to a screw that goes down inside the humerus bone. And that's looking at it on the side view, again, the ball and socket rubbing, and that's what it looks like on the bottom right picture. Again, a nice smooth surface now, and that gets rid of probably 85 to 90% of the pain from the shoulder. The advantages are very, very good. It's a smaller operation. You get immediate pain relief. It's less to go through and minimal bone sacrifice, and you're not taking as much bone out. You can always convert that to a bigger operation at a later time, so you don't burn any bridges by doing this operation. You can also go ahead and repair what's called the rotator cuff, which are the muscles and tendons that move the shoulder. So that's shoulders really briefly. Now quickly, I just want to touch base on hip arthritis as well. A lot of people, again, that have knee arthritis are going to have some issues with their hip as well. And again, as far as surgical options, there's total hip replacement. That's been around for a long, long time, and nowadays the components are excellent that do total hips. There are lots of different companies, again, that make that, and the results are very satisfying. Again, there's the option of, just like in the shoulder that I showed you, you can resurface the ball if there's a localized area necessary. Again, for a young person, that sometimes can get people by and buy some more time for them. Or there's the option of hip resurfacing, and that goes by the term that people hear about, and it's bandied about, and it's in the paper. It's called a Birmingham hip resurfacing, and I'll go into that in a bit more detail. So this is what a Birmingham hip looks like. Instead of the traditional hip replacement where you remove a large amount of bone, basically you try to keep as much bone as possible. There's a cap that covers over the socket. There's a little cap that goes over top of the ball, has a small little stem that goes down inside the ball. And in essence, you basically keep your own hip. You're just trying to cover up the arthritic surfaces. It was named for a Dr. McMinn, who actually is from Birmingham. That's where this joint was created. This type of concept has been around for many years, and actually we did similar procedures way back in the 70s. Unfortunately, the materials back then were not very good. Materials now are very, very good. So now it's metal against metal. There's no plastic in this whatsoever. So the constraints, the design had to be absolutely perfect for this to glide inside this. Who's a candidate? Typically people that are younger, under 60 often. If you're over 60, you have to be very, very careful who you select this operation for, because there's the potential for increased complications from it. But for a young person that you don't want to do a standard hip replacement for, this again can buy more time for their hip. So the anatomy of a hip, there's the socket, there's the ball, the femoral neck, which attaches onto the shaft, and then again that white, smooth, pearly cartilage covering that covers over top of the ball and covers over the socket. That's what you want in a normal hip. When you have arthritis, again, those surfaces are worn down. It's wear and tear. The joint becomes pitted and eroded. You develop a lot of bone spurs. And again, because of that, you can imagine how much pain that would generate and prevent people to be active. The x-ray on the left shows a normal appearing hip. Again, the space between the ball and the socket is relatively clear. On the arthritic surface over here, there's no space left. It's bone rubbing right against bone. Very painful, restricted range of motion. Even nighttime, trying to get relaxed and comfortable is sometimes very difficult. Some people are born with problems with their hips, and they develop what's called hip dysplasia. And some children that are born, babies that are born with a dislocated hip and the hip is not put back properly, as time goes on, they develop significant arthritis, and they don't even actually form a proper socket. The ball just rests up against the side of the pelvis here, and again, there's no socket, so it develops bone against bone. Again, very, very painful. Oftentimes has a very shortened leg as well, and a very unusual gait pattern. This AVN is another problem. It's a circulation problem to the ball. It prevents the ball from having replenishment of the calcium inside. The ball becomes very soft as time goes on, and it then develops into significant arthritis. Very, very painful. Happens in people that are alcoholics. It happens to people that take long-term cortisone. It can happen in people that are deep-sea divers, for example, and get the bends. There's all kinds of reasons why you can develop this AVN. But even still, you still want to try non-surgical options unless there's no hope. And again, you try to modify lifestyle. If they're out running and jogging, perhaps you'd stop them from doing that and ask them to ride a bike or use an elliptical trainer or a glider or just walk instead of run so they don't just impact load on that hip all the time. Change their regimen for exercise. And again, try anti-inflammatory medication. Exercise is actually very, very good, but you have to be limited. And if it hurts too much, you have to make sure you don't go by the concept, no pain, no gain. If it gets to be really, really uncomfortable, you need to slow down. And a healthy diet can also help to reduce weight loss. And weight loss is certainly a major role, especially in Louisiana, to try and get stress off that joint. All different kinds of medications, even heat and cold can help. Anti-inflammatory medications, same sort of concept we talked about briefly on knees. Again, you can try everything from anti-inflammatory medications over the counter like Advil and Aleve to prescription anti-inflammatories. There's topical medications you can put on the hip. You can take pain medication, and sometimes even a cortisone shot into the hip joint can be very, very helpful. So a conventional hip, there's the ball. You basically remove the entire ball in the neck, and you go ahead and clean out the socket. You put a new socket in its place that has a liner inside and this large component that goes down inside the canal. You'll see a brief movie in a second. That's what a conventional hip replacement looks like. Oftentimes nowadays we don't use any cement. It used to be we would fill the canal with cement, a special type of bone cement, and then pour this into it and it would get fixated with the cement. Now the components are made with this very, very fancy kind of material on the side of the metal, and it's a very rough surface, and the bone actually from your own bone will grow in and lock it in place, much like a fracture that would heal. In the Birmingham hip, a little bit different. Again, you go ahead and core out the socket and put a new socket, but basically you save the hip, but you basically ream it down to this kind of configuration. You put the new liner inside, this cap goes over top, and you still have all of this left on the far right-hand side, unlike a traditional hip replacement. So again, that's the difference between the conventional and the Birmingham hip. That's what the x-ray looks like on a Birmingham hip replacement. That's the socket up here on the far right and the cap that goes over top of the ball. Again, traditional hip, oftentimes we use plastic inside here between the metal and metal. That's the socket liner, a plastic liner inside of that, and then a metal head that goes on top. In the Birmingham, it's all metal against metal. And nowadays, with a standard hip, we have all different kinds of bearing surfaces that I'll touch base in a second on. We don't have to use plastic. We have ceramics and other metals we can use as well. So again, what you try to do is conserve as much bone as possible for somebody who has arthritis in their hip. So after surgery, as with the knee replacement surgery, a very strict rehabilitation protocol to strengthen up the hip. Typically, in my cases, if they get operated on early enough in the day, they can walk on it the same day. And again, hospital stay depends on their age and the requirements. Anyway, from an overnight stay to sometimes 2 to 3 days is required. During the first year, you have to be relatively careful about your activity level. But as time goes on, after 1 year, you can resume much more aggressive activities, especially with the Birmingham hip replacement. A little quick video here showing you the difference. That's a standard hip replacement. Core out the socket, take off the ball, put a new socket liner in place, and put this new component down inside the shaft. The ball goes on, you reduce the hip back in place, close the hip back up again. Obviously it takes 30 seconds to do the operation. They can walk on it right afterwards. That was a joke. This is the Birmingham hip. Again, similar, but again, you keep the femoral head and neck, and that's basically the difference between the two. With latest technology now, even with a standard hip replacement, we do this through a very small incision. If you're relatively small, we can make the incision typically 4 inches in length to be able to do the operation. So there's very little blood loss and a lot less pain than the standard old-fashioned operation, which would require a large incision. Again, now we can use metal on plastic. We can use ceramics inside the hip. And there's the option of using metal ball on a metal socket, even for a standard hip nowadays as well. We use what's called multimodal anesthetic options, so people get pain medication before the surgery. They often have the surgery done under a spinal or an epidural anesthetic, so you don't need to be knocked out completely. We do all these injections around the hip joint of all different kinds of medications to ease the pain afterwards. And typically they have very little discomfort for the first 24 hours after the operation, and allows them to get up and get going very, very quickly. Short hospital stay, again for young people, we've even done this as a day surgery and they've gone home the same day. Again, the anatomy of the hip that you saw the other pictures for, the acetabulum, which is the socket, the femoral head, which is the ball, and the femur, which is that it's attached to. Again, that's a picture of arthritis, significant arthritis of the ball and socket, very, very painful. We often get a dull aching pain. People often come into my office and say it hurts in my hip joint, and they point right back here. That's not where the hip is, actually. The hip joint actually is deep inside the groin, straight through to the buttock, and sometimes on the side. X-rays are important along with clinical examinations. Sometimes we do an MRI scan, and there's blood tests you can do as well, although they're not very informative for arthritis. Rheumatoid arthritis, it may help, but even still, that's not 100% accurate. So what you offer people by doing these operations is a return to mobility. You regain a sense of your old lifestyle. It's amazing and very gratifying to have somebody who comes in that can barely walk, and they can't go to Walmart, they can't play with their grandkids, they can't do the things they want to do. You do the operation, and very quickly they respond, and it's almost like night and day, the response on hip joint replacement surgery. It's actually easier to recover from a hip joint replacement than it is from a knee. Again, non-surgical options are cortisone injections and anti-inflammatory medications, walking aids like a cane or a crutch or a walker, and rest and activity modification can help before surgery as well. So when is hip replacement surgery right for you? It's when you get to the point where you can't go any longer, basically. And it's a decision that the patient makes. It's not a decision that the doctor makes. And oftentimes we give patients the opportunity to ask lots of questions, and we say basically, when you're tired of your hip pain and it doesn't allow you to do the things you want to do, that's when you can decide you want to have it done. It's not for me to, based on an x-ray, even if there's bone against bone, to say you have to have it done. Again, a standard hip, that's the metal socket, typically a plastic liner, but that can be made out of ceramic or metal. There's the ball, and then the standard component, again, that has this sort of very unusual shell surface that the bone grows into. Another picture of it. Again, there's all different kinds of liners you can put inside, plastic, metal, and ceramic. There are specific issues you need to address after the surgery to make sure that you can use that hip very well. Physical therapy is a mainstay of the post-op treatment. Lots of people have hip replacement surgery. When you're prepared, there's all kinds of information that the doctor will give you as to how to get ready for the operation. There's all kinds of information that's available on the web. There's all kinds of information in brochures and handouts, some of which are here today. You're more than welcome to take. And there's all kinds of videos available as well to get more information about replacement surgery. After the surgery, typically we have people walking the day of. We use pain medication as necessary, but we keep patients very, very comfortable, and it's important to keep ahead of the pain. Hospital stay is variable, anything from day surgery to 2 to 3 days. And discharge, when we send people home, we have home health nurses that come out to the house. They monitor the incision, they do dressing changes, and they do physical therapy at the house as well. Very important on hip replacement surgery, one of the potential complications is dislocation, and very important to follow the instructions as to what you can and can't do with that hip. You don't want to get it into awkward positions. You don't want to flex it too much if you can help it beyond 90 degrees. So in other words, you don't want to try and bring your knee up into your chest. You don't want to bend over too far. Again, 90 degrees is acceptable, but bending beyond that for the first 3 months would be something you would not want to do. Again, you do physical therapy very, very quickly to regain strength in the hip, and the pain medication decreases relatively rapidly after the operation. Limitations on what you can do, but weight bearing typically as dictated by the surgeon. We typically have our patients fully weight bearing very quickly after the operation and get more and more motion back in the hip, which has been stiff for many years. After 6 weeks, you can start doing more and more activities. Typically, people come into my office 3 weeks after surgery, perhaps on a cane. Usually by 6 weeks, they're even off the cane. They get back into a much more normal routine, and they can get back to work, depending on their work requirements, relatively quickly as well. Typically, that's coming from your kneecap. That's where some arthritis may be present. There's, again, medication you can use. Physical therapy can help strengthen the quad muscles that control your kneecap and give you the strength and power to be able to get up from a seated position or sit back down again. Sometimes an injection can be helpful as well. So when you're standing and walking, you're basically putting weight between the femur bone and the shin bone. And if there's not much arthritis or problems with the cartilage pads between the two, that's why you're doing quite well. But the kneecap glides over the front of the knee, and when you bend and straighten that knee, then that kneecap glides up and down in a groove on the front of the knee. When you're in the act of standing up, or when you're in the act of going back down again, or even going on stairs and putting a foot on a stair and pushing up, what you're doing is the muscles on the thigh bone are contracting and basically compressing that kneecap up against the thigh bone. And again, if you have arthritic wear back there, that can be very painful. Okay, so if you don't have grinding or... Yeah, but if you don't have grinding or popping, then that means the arthritis may not be that significant and an injection may help you. Oh, entirely different drugs. Cortisone is an anti-inflammatory medication. It helps to cut down inflammation in the joint. And the gel medications, the lubricating medications, are not even in the same family. That's actually a synthetic form of the same fluid that you actually have inside your joint. All joints have a fluid called synovial fluid. It's a lubricating fluid inside. And so they've synthetically made that type of fluid, and by putting that in there, it can help to cover up defects inside the joint and lubricate the joint so it doesn't hurt as much.